Hello, this is Endovascular TV, and we are in Barcelona in the 51st Congress of the European Society of Phlebectomy. We have the honor, I'm honored to interview Paul Pittaluga. He's very well known by worldwide for a lot of things. I'd like to make some comments about his meeting, a very well and successful meeting he organized together with Dr. Chastanet from 2007 in Nice. Paul Pittaluga has a long career, a brilliant career, and not only organized this meeting in Nice, but I knew that you have organized in Alexandria a few months ago.
Last year, yes.
Yeah, I hope it was a success.
It was a success with a lot of people from Egypt, and we got more than 90% of the vascular surgeons from Egypt. And
90%?
90%, and more than 350 people attendees to this meeting, so it was a great success for the Middle East.
It's a great success. So I want to make point out something very interesting, because Paul Pittaluga became very well known all over the world by his strategy. He published a lot of papers about the asphalt technique. I would like to know, how do you summarize this technique in order to make easier to understand to all the people how it works?
First of all, we have to explain what is the physiopathological basis for this technique. This technique is based on the ascending theory for the development of varicose veins, in which the evolution comes from the tributaries, from the varicose tributaries, to the saphenous vein and to the saphenous junction. Therefore, in this concept, you can limit the treatment to the tributaries in order to improve the saphenous hemodynamics, and therefore the symptoms and the chronic venous insufficiency. That is the basic principle for applying this technique. Afterwards, the technique is very simple. It leads to remove the tributaries. We do it by phlebectomy, and the technique is very simple. It's done under local anesthesia and with a very gentle surgery, mini-invasive, non-aggressive, without hospitalization, and it's very cheap to do.
Okay. So one question, so I don't want to offend you, but I'm thinking about, how is the origin? You began to do phlebectomies and afterwards you saw that it works or not? Or you study which is the physiopathology and decided that the theory of asphalt is the correct theory?
It came from my vascular surgeon background. I've learned at all vascular surgeons that the problem is coming from the saphenous vein and especially from the junction.
Yes.
Therefore, I've done thousands of high ligation and stripping. But when the endovenous techniques came and emerged, I was a little bit concerned by the absence of crossectomy, of high ligation.
Yeah.
And I observed that despite the absence of high ligation, the reflux at the junction disappeared.
Yeah.
And looking at the results at midterm of the endovascular techniques, the frequency of clinical recurrence on the tributaries was at least the double than the frequency of the persistence of a reflux in the saphenous vein, which has been treated by laser or radiofrequency, which means that despite the correct ablation of the saphenous trunk and the absence of prostatectomy, you had a lot of clinical recurrences. And in my mind, I began to think that maybe the saphenous vein is not at the center of the problem. In addition, I began to do ultrasound, which is not usual for vascular surgery in France. And I've noticed that in almost 50% of the patients, there is no reflux at the junction when there is a reflux on the saphenous trunk. And in 90% of the cases, below the connection with the tributary, there was not reflux on the saphenous trunk.
No, it has been a revolutionary observation. I would like to make some comments. I would like to know your opinion, because there is some misunderstandings between Chiva strategy and ASVAL strategy. There are common points, but there are other points that we are not talking about the same. So please, could you briefly explain?
It's very important to clarify this point. Chiva, which has been described before ASVAL, 20 years ago.
Late 80s, yes.
And ASVAL has the same principle of sparing the saphenous vein.
Yeah.
That is the only common point.
Yeah.
On Chiva, there is no in Chiva there is no calling into question of the descending theory. That is the opposite for ASVAL. In Chiva, the principle is to drain the reflux from the superficial to the deep by doing ligation on the saphenous vein. In ASVAL, the goal is the recovery of the saphenous trunk by any kind of gesture on the saphenous vein, complete respect of the saphenous vein. And remember that in the first description from Franceschi in Chiva, there is no phlebectomy. He said that the varicose veins will drain by themselves in the deep venous system. You just have to wait. And in ASVAL, there is exactly the opposite, because the goal is to remove the varicose reservoir, what we call the varicose reservoir.
Probably has been one of the questions that Chiva has not success, because the phlebectomy, it seems to me, in my experience, the major part of is necessary. I think it's necessary in the major part of the cases. So we know you have a mastery in different techniques, but moving on the novel techniques, I know that you want to spare the saphenous vein, but do you indicate any endoluminal treatment? Do you think
that is another difference with Chiva? There is limits for ASVAL.
Yeah.
For Chiva, you can treat.
Never.
You have always to do Chiva.
It's a thing. It's a sign.
Yes.
Yeah.
In ASVAL, as the chronic venous insufficiency is evolutive, there is a stage in which the saphenous vein is over, is too damaged to be spared. Therefore, we have some indication for endovenous techniques, and in our daily practice, it represents between 10 and 20% of our procedures, in which we ablate the saphenous trunk. And there is different. It's difficult to simplify the indication because you have multiple factors. But for summarize, when the saphenous trunk is too damaged, because the saphenous reflux is very long, the saphenous vein is very dilated, or there is too much varicose veins with on different branches, the best option is to ablate the saphenous trunk. So there is indication and contraindication for ASVAL. Okay.
So have you had any experience in the Sapheon technique, in the cyanoacrylato?
I have no experience, but I think that if it's based on the same principle to occlude the saphenous trunk, if this occlusion is efficient, safe, and will last for a long time, there is no reason to think that there is no indication for this technique. The advantage is the absence of tumescence, of the need of tumescence. The only question is that you put a glue for which the chemical principle is not really well known at long term. So you don't exactly know what could happen in the future. the only studies has 1 year of follow-up only. So, but in the principle, there is no reason to think that it doesn't work.
And finally, I would like to know your opinion about the office-based treatment. You have a very successful clinic in Nice, and how do you treat your patients in the daily basis? You try to go to the operation room. You are beginning to do it in the office. Which is your practice?
So actually, we have moved to Monaco. We are not. We are not
in Nice.
In Nice.
Okay.
We are in Monaco since 2 months ago. It's a very important point. We are handling the patient in order to do as minimally invasive as possible, including in the global handling of the patient. We try to do surgery by phlebectomy under tumescence and etc., as we should have done sclerotherapy.
Okay.
As close as possible to that. But there is some legislation in France and in Monaco from which we still have the necessity to go to the operating room. But we have set up a protocol with which the patient can come at the clinic 1 hour before the surgery and can go out just 1 hour afterwards, and in 90% of the cases without any workout of time. It's very, very similar to the sclerotherapy.
Okay. So we could spend hours talking with its brilliant and expert. The only thing I can say is thank you very much for attending Endovascular TV. It's a pleasure. I told before we are here in this Congress with the cream of the phlebology in Europe. Thank you very much.
Thank you.